Dear friends in international phlebology, especially dear women friends, or there in Istanbul, where I am so sorry cannot be now with you. My talk is about intermittent pneumatic compression, IPC, in lymphedema compared with manual lymphatic drainage, MLD. The material for the study and the statistics evaluation was paid by Bösel and Bauerfeind, but my personal work wasn't reimbursed. Lymphedema is a chronic disease, you know, everybody, and it used to be more frequent after surgery and radiation, but in Germany now it is most frequent for obesity. So the secondary lymphedema is the most frequent we have to deal with, and due to obesity it is really a financial problem for the healthcare, which reimburses the manual lymphatic drainage for these patients. So how to treat the lymphedema? We first have to reduce the edema with bandages and starting lymphatic drainages if necessary, educate the patient and so on. And then after this initial reduction, we have a long phase of maintenance of the status quo with compression and with lymphedema, manual lymphatic drainage up to now, but this is a high cost position. What is intermittent pneumatic compression? It is these kind of devices which fill themselves up with 12 chambers from the foot to the groin, or even as a hosiery in cycles. It fills up in 40 to 60 seconds. You can change this at the device, and you repeat this once and again, and the duration should be 30 to 45 minutes. And the pressure is really selected by the patient. It can be vary between 35 and 115, as we saw in our study. In lymphedema, the German guidelines recommend the use, but there is no study comparing with manual lymphatic drainage on the chronic point of view, only on the short way. The advantage is patients can apply it at their home when reading, watching TV, or having their siesta. And the disadvantage is that some patients have pain when the pressure comes, for example, or discomfort when they have knee arthrosis. The study design the question was, is there a difference in the results of the treatment if you use only compression and manual lymphatic drainage, as they are used to in my office, compression plus IPC, or compression plus lymphatic drainage and IPC. Tools to measure the results were quality of life, the International Lymphedema Function Questionnaire, circumference of ankle, thigh and calf by manual measurement, and leg volume by the Bodytronic, which is a device that electronically measures the volume and the circumferences of the leg from Bauerfeind. We selected the patients that are in our office in the treatment, in the maintenance phase of the lymphedema, and we took only patients that in the last year had only a change of their BMI of 5% or less, and they had less than 10% of changes of the perimeter, which we measure each time they come every 3 months. The ethical approval was given, and the exclusion criteria was, of course, pregnancy, if they are really ill with other 2 or more, if they were starting a diet, or if the weight was over 150 kilogram, because the device, the Bodytronic, can't measure them. The flowchart is they were chronically in compression and MLD. They had the admission, they filled in the questionnaires, and then they were randomized in group 1. They started with compression and IPC first, then had one washout phase of 4 weeks with, as always, compression and manual lymphatic drainage, and then again 4 weeks with compression, IPC and MLD. And the other group had the compression, IPC and MLD in the first 4 groups, then 4 groups wash out with compression and MLD, and then the last 4 weeks with compression and IPC. So we had a kind of crossover study design. We included 20 participants, and the ethics committee was okay with, after 20 participants, to have a look if there is enough value, if there is enough power and strength for the study. Otherwise, we should have included 20 more. But with 20, we did perfectly well. 2 were lost. One with knee arthrosis, they had discomfort, and the other just had discomfort and didn't want to participate anymore. The mean age was 59.6. The BMI at the beginning was 33.7 in the mean value. The lymphedema was present since 7.7 years, and they had a manual lymphatic drainage since 6.4 years. 11 had both side lymphedema, 5 only right and 2 only left. And the type of lymphedema was primary in 5 patients and secondary in 13. We made an evaluation. Each line is a patient, and we controlled how they changed the values throughout the study. And the perimeter of ankle and calf, these lines are really, really steady if you look at them. The values were steady for the perimeter. The values were steady for the volume. Each one of them is, this one is before, this one is after the MLD phase, this is after the IPC phase, and this is after the both phase. So we can see that the results were really, really astonishingly equal. And if you look at the standard deviation of the differences, you see that the middle differences between the groups were really irrisory. This is centimeters, 0.13 centimeters. The only one statistically significant was the perimeter at the calf, at the ankle, compared both to before treatment and both with compared to only IPC, but we are talking about 0.22 centimeters. So this is really not a significant, not a clinically significant reduction in difference. Concerning the quality of life, we have a little bit of more variability. If you look at the lines, if you look at the quality of life, the overall is really steady. But if you see that there was a significant deviation comparing to before, this means in any phase of the group they felt better than before starting, and this is known as the placebo effect. Because if you then compare them among them, there was really no difference, even if you compare to them with the phase where only MLD was applied. But the changes were really so little that you can't make a real difference out of it. Then they had last questions like which one was the optimum for yourself, and you see that the results of these answers are very, very equal between all the groups. When was the time management the best one? Combining an MLD and the IPC was very good, no difference. Choosing both could be too much for 2, enough for 14, not enough for 2. So in summary, there seems to be no difference in the long maintenance phase in volume and quality of life comparing lymphatic drainage with IPC. And lymphedema is becoming a financial burden for the patient in the countries where he has to pay, for the system in the countries where the system pays, and for the fuel you have to use to go to the place, the time you have to apply to go to the place, the physiotherapy time and costs. You could apply the therapeutics for other patients, perhaps in more urgent need of that treatment. So I personally propose a mixed concept, not taking the patient completely out of the physiotherapist's place, but having a visit once a month and not once a week or twice a week, and the rest of the time self-administering the IPC. So thanks for your attention. This was it. I'm very sorry not being there, and I hope to see lots of you in Hanover in the Congress, in the meeting where I'm the president, just in 2.5 weeks, in Hanover Congress Centrum with an international strain, so everybody could be there. And then you can visit these nanas, which are figures we are all around in Hanover. Thank you and good luck.